Good afternoon, everyone. Welcome to Health Talks, a production of the College of Health Solutions at Arizona State University. Just a reminder, this presentation is being recorded and will be available on our website after the conclusion of this webinar. We invite you to put questions into the Q&A box at the bottom of your screen, and we will address them throughout the presentation. Without further ado, please welcome Swapna Reddy, Clinical Assistant Professor with the College of Health Solutions.
Hi, and thank you so much, Marcus, for that introduction, and welcome all to this really important and relevant conversation today. Today we're going to be speaking about vulnerable populations, but very specifically the effects of the COVID-19 pandemic on racial and ethnic minorities. And we're at a really acute moment, it feels like, in our society where we're really talking about two different viruses. One is the COVID-19 virus, which is fairly new in our society, and the other is really inequity and inequalities, systemic inequalities, more often than not, that relate to race and ethnicity, and those are quite old in our country. We're also at a moment where we are thinking about two very specific issues, not just in the United States, but here, especially in Arizona, where many of us sit, which is the rising rates of the COVID-19 infection in our society and also hospitalizations. But also number two, after the tragic death of George Floyd, really an increase in, some of us feel, unprecedented dialogue as it relates to race, as it relates to inequality, and as it relates to systemic injustices. So when we think about systemic injustices and what that dialogue looks like, it really pushes us to think, which systems are we talking about? And so often, a primary system that we need to consider when we're thinking about inequity and disparity in the United States is the healthcare system. So without further ado, I'd like to introduce our panelists for today, who are going to really speak about the staggering and really tragic inequalities during this pandemic, and how really historical reasons and current inequities have lent to those disparities during this pandemic, very specifically to the African American community, our American Indian communities, and our Latinx communities, not just all over the United States, but we have felt some of these inequities very specifically here in Arizona as it relates to our Native populations. So today it's my pleasure and my honor to actually moderate, but really just sit and listen and learn from our great panelists today, from their experience, from their perspective, and also to think a little bit about actionable solutions. Our panelists today are Dr. Ed Baker, who's the Medical Director of Equality Health, Dr. Gilberto Lopez, who is the Assistant Professor at ASU School of Transborder Studies, and Dr. John Molina, who's the Corporate Compliance Officer of Native Health. So at that, I'm going to stop and switch it over to Dr. Ed Baker. Dr. Baker?
Good afternoon, everyone. Dr. Ed Baker here. We're going to talk about COVID-19 and racial disparity. Next slide, please. Well, first of all, the numbers don't lie. As you can see here, this is as of the 18th of June in the world, how many deaths? There's 8 million confirmed cases with 449,000 total deaths in the world. Arizona at 40,924 confirmed cases. The important part is you see the total amount of deaths at 1239. The important part is that over the last 3 days by themselves, there's almost been 5,000 confirmed cases. So just in these few days, we've had more cases than we did almost by the end of April. So this is a work in progress for us. Next slide, please. I want you to take a look at African American statistics, and this is in the country as well as several states that I've mentioned. As you know, African Americans are 12% of the population in the United States, yet 24% of the total deaths so far by COVID-19. You can see what has been transpiring in some of the states like Mississippi, where over half, and Louisiana, over half the deaths have been to African Americans for COVID-19. Arizona has not quite shown that, but I'm going to show you a slide in a moment that can explain why those numbers still don't show anything important yet. Next slide, please. Briefly, want to talk about the Native Americans here, and I know Dr. Molina will soon talk about this as well, but in the state of Arizona, where about 4% of the population have 20% of the deaths due to COVID-19. So very similar to what African Americans have been facing across the country. Next slide, please. From the Arizona Health Department, they publish information regarding deaths by COVID-19. And this slide, in Arizona, 8% of the COVID-19 deaths are not associated with race, as you can see where it says unknown. These numbers in Arizona are not perfect, but definitely much improved from where they've been even last month, where the unknown was nearing 20%. Next slide, please. Now, this talk I've given is not meant to be medical or science in nature, but I need to make sure that we're all on the same page as we go through these, make sure we have the same understanding. Current pandemic is caused in part by this virus. Its name is SARS-CoV-2 and has never been seen prior to December of 2019. Belongs to a family of coronaviruses, and most coronaviruses are really mild in nature. They cause flu-like symptoms, but there are a few, like the SARS virus in early 2002 and the MERS virus in 2012, which cause more severe symptoms like this current virus. Is known as, the disease it caused is known as COVID-19. Next slide, please. Next, thank you. So the general population is beginning to see that racial disparity is real. And what we were dealing with was that virus, but now we're also dealing with this combined. There's now been a conversion of viruses, as Ms. Reddy so adequately has stated. Racial disparity has a huge negative impact on the health outcomes. One slide here shows how medical disparity plays out with neonatal mortality. As you can see, 38% of the births in one county were African-American babies, yet 71% of the neonatal deaths were African-American babies. And the other slide shows how judicial disparity plays out with disproportionate incarceration of African-American men, where all men, 1 in 9, are being incarcerated. You see 1 in 3 African-Americans are being incarcerated. Next slide, please. So the United States is being touted as a world leader in medicine, but in the words of the famous Mike Tyson, everyone has a plan until they get punched in the mouth. And that goes to talk about our pandemic preparedness. Next slide, please. Real brief talk about understanding 2 very important terms, that's equality and equity. Even well-known scholars get this mixed up sometimes. With regards to healthcare, equality in healthcare means everybody gets the same thing. You walk in, I'm gonna treat you with medicine for your blood pressure. What equity does, it allows me to treat the patient, give them what they need to achieve their best health. So they may not just need medicine. They may need transportation to the clinic. They may need us to decrease our costs because they can't afford it. So, and they also may need me to increase the hours by giving telemedicine visits. These are all things that remove barriers that allow people to have access to care. Next slide, please. So this is a slide that just talks about who's most at risk for serious illness. And whereas 80% of those infected with COVID-19 will have a mild to moderate course, the early publications out of China showed that a subset of patients were having worse outcomes, and those were the elderly, those with chronic diseases, and those that were immunocompromised. Next slide, please. So I became worried back in February when I started doing these talks, and most of my talks are more medical in nature. And that's because African Americans, I knew would be more adversely affected because they are disproportionately higher with heart disease, lung disease, diabetes, all the things that make you more susceptible to worse outcomes. I just want everyone to understand, though, there's one other thing that's not included, and that is poverty is a public health issue, and it does affect us greatly. Medically, we have an immune system, right? It helps us fight off these infections, but our social determinants of health, things like education, economic stability, healthcare, neighborhood construct, social construct, they all have a clear relationship with respect to health outcomes, including elevated disease risk and premature death. Often the members of marginalized communities have jobs that don't translate well to virtual substitutes. People like transit workers and many other jobs have high touch environments, and they would do well if they were provided with the proper PPE, protective equipment, but often they're not. Social distancing is also difficult in homeless shelters, close quarter housing, prison system. And so more protocols need to be put in place to make sure the safety for everyone is taken into consideration. Next slide, please. So there are many studies that attempt to find out why people of color have worse outcomes, even after accounting for those social determinants of health. I'm an OBGYN by training, and I've been a part of several studies that look at preterm delivery, preterm birth, and also neonatal mortality. And African-American women, even those that have the same job, same education, make the same money, live next door to each other, have worse outcomes. So it's been argued that systemic disparity and injustice cause higher levels of cortisol in systemically oppressed communities. You can see on the screen, there's several different diseases and how they affect people between 60 and 75. And African Americans sit at the top of most of those. Next slide, please. It's been well studied. Elevated cortisol leads to depressed immune system, which can make you susceptible to many things. Now, just a brief understanding of cortisol, that's our stress hormone. So when we've been frightened, we've been, back in the day, a lion jumps at us, we need to be frightened. We need to have increased blood sugar because we need to run. We need to have a heightened attention span because we need to know where we're going. We need to have an increase of blood pressure so that we can get our blood circulating and get away from all the things that we thought are dangerous. However, in systemic racism, our elevated cortisol does unintended things, such as it suppresses our immune system, which can make us have worse outcomes. It decreases serotonin to give us possible depression. And also, African Americans and other people of color are often not given the same pain medicines when in the ER. They have decreased sensitivity to pain, right? These things all lead to worse outcomes. Next slide, please. So improving outcomes, there's several things we can do. With regards to COVID, we need to continue those best practices, those things like washing your hands, social distancing, wearing masks when you're out in public, staying at home, unless you gotta go out. This will pass soon enough. We just need to protect ourselves so that we can protect the vulnerable people. Also improve the stream of education to make sure it's culturally competent and available to the masses. We need to improve community testing. Everyone should have access, whether you're symptomatic or not. And also, lastly, advocate for public policy initiatives that address issues that concern our community. And the three people that are talking today, we all live in the same community. We all need these initiatives to be addressed as soon as possible. I will yield the rest of my time to my esteemed colleagues.
Thank you so much, Dr. Baker. You gave us so many things to think about here. I just want to echo Marcus's note in the chat that we're open for questions, either during and between each presenter, or we can certainly wait until after as well. I also was told that during my introduction, I had my background on and not my face, so I apologize. 3 months into Zoom every day, and I apparently still don't know how to use it, so I apologize about that. But are there any, if there's no other questions yet from the group, I wonder if we could go ahead and switch over to Dr. Lopez.
Yeah, okay, let me try to share my screen. Okay, can you see my screen, my PowerPoints?
Yes.
Okay, so hi, my name is Gilberto Lopez. I am an assistant professor here at the School of Transborder Studies. And I'll be talking briefly about, I'll give a little bit of a background of COVID-19 in the Latinx Latino community, but most of the time I'll focus on two projects that I'm working on to address misinformation in the Latinx community, specifically COVID-19 misinformation and information in general in the Latinx community. So the context. So we know, we saw some of the data Dr. Baker was mentioning about the disproportionate effect of COVID-19 in a lot of these racialized minority communities, the Latinx, the Latino community being one of them. And we see that this is disproportionately affecting them, maybe not so much in the data that you're showing from Arizona, but nationally we see this. And yet, as you mentioned, Dr. Baker, as well, the social determinants are a big they contribute to this unequal distribution of the disease. Where we sleep, where we work, and where we live affect this unequal distribution. For Latinos, the Latinx populations, they are disproportionately working in these jobs that we call the 3D jobs, jobs that are dirty, dangerous, and demanding. They are low-paying jobs, very high-stress jobs, and as again Dr. Baker mentioned, the effects of stress, chronic stress on the body and on populations. So you have a population that's working these jobs, these essential jobs, very limited protection at the work site, whether it's agriculture, service industry, construction, these types of jobs, very little PPE. And again, these jobs are low paying. That limits where individuals can live, who they live with, how many people live in your household. That has implications again for the disproportionate distribution of this disease. I won't get too much into that. I just wanted to use that as a background. There's a lot of data coming out specifically on that. So one of the factors that I was interested in because of my background in health communication and also looking at some of the immigration and health, migration and health, is that we found that there's a lot of misinformation and a lot less of quality information coming to the Latinx Latino community. So the same information that we're getting from our governments, from organizations about best practices, how to prevent, and where to go for treatment of COVID-19, that same quality and the same amount of information is not coming through to the Latino Latinx community. There is, going on the CDC website, there is some information in English and there is some information in Spanish. However, it's not culturally tailored to certain subpopulations of Latinx immigrants or immigrants from Latin America. The indigenous communities, Mixteco, Zapotecos, the Mayan communities coming in, whose primary language is not Spanish or English. And there's also a lot of misinformation. And a lot of this is circulated through social media, specifically platforms like Facebook and WhatsApp, which are used as networks of information for a lot of these migrant communities. So what we did is we started a sort of a mixed method approach, a research to understand what is the information, what is the quality and the quantity of information coming through to the Latinx community about COVID-19. And then as sort of converging with a second project that I'm working on, creating an animated series to bring information in a culturally tailored way to this community. So the first project, again, it's a mixed methods research project. We're trying to understand beliefs, attitudes, and behaviors. The theoretical framework we're using is Arthur Kleinman's kind of explanatory models to make sense of illness, make sense of disease in different communities in order to do sort of a comparative analysis of the way people make sense of this. This is being done in collaboration with UC Merced. And it's the site, the location we're doing is California Central Valley, which is an agricultural region in California. with a very high percentage, majority of Latinx farm workers and people who work in these 3D jobs in that area. So we started off with some in-depth interviews with 40 individuals, 40 participants. And then we're scaling that. We're coming out of those interviews, we designed a survey that we're starting to field this month, trying to capture in an 11 county catchment area, trying to survey at least 1,000 individuals, Latinx individuals in rural California. And this is done online, an online survey. And the goal is to follow up in 12 months and 24 months to try to see if there are changes and what the effects of COVID-19 is having on this population's knowledge of COVID-19, but also on their socioeconomic well-being. Are there changes? What changes are there in this population? The second project is a help animation. So we started a project called the CHAT, the COVID Help Animation Project, partnering with an organization that does animations. And we're doing a series of culturally tailored animations. So I'm gonna show you a quick 1.5 minute animation that we rolled out. That's the first one that came out. But what we're trying to do here is use the data that's coming from the project that we're doing in the Central Valley to inform the animation. So how do people understand COVID-19? What are their misconceptions? Where are they getting their information from? And then try to see if we could, in a culturally tailored manner, create these animations to maybe refute some of this information, but also to bring more appropriate information to the community. So let me just share my other screen really quick, and it's just the video. Okay, can you see the animation? Okay, I'm gonna share it.
Lo hacemos, dice. Así, así.
Don Francisco, me encanta esta canción, pero la colita se debe quedar en casa. ¿Por qué motivo? Por el coronavirus. Déjenles explico. El COVID-19 es un nuevo coronavirus, una familia de virus que afectan el sistema respiratorio. El virus entra al cuerpo por los ojos, boca y nariz y se extiende a los pulmones y se multiplica rápidamente. El sistema inmune se activa para contrarrestar el virus. En la mayoría de los casos, el sistema inmune de las personas resiste y elimina el virus y tendrán síntomas templados o incluso ningún síntoma. Pero personas de edad avanzada con condiciones médicas como diabetes, cáncer y problemas cardíacos son más propensas a enfermarse porque el virus causa daño a los pulmones. Algunas de las personas necesitarán un respirador artificial y algunas personas, desafortunadamente, fallecerán. Es por eso que debe evitar tocarse la cara con las manos.
O lávense las manos al tono de feliz cumpleaños. ¡Feliz cumpleaños a ti! No sean como este muchacho que se la pasa visitando todo el mundo. Quédense en casa.
Lo hacemos.
My PowerPoint. So this is the first sort of pilot that we did. The information here is just basic information. It seems basic to us as researchers, as people who are kind of trying to stay up to date about best practices. But even information like this simple information of stay 6 feet apart, wash your hands, is disproportionately coming through to different communities. The Latinx community, different subgroups in the Latinx community or indigenous immigrant communities are not getting the same quality information. So again, we're trying to bring that information to this community in a culturally tailored way. In this case, with this video, we use at the beginning a cultural icon in Latin America where, you know, he could be problematic or he is problematic at times, but he is an image. Don Francisco is someone who almost every Latino you ask is gonna know who he is. So we used him to start the video. here we use J-Lo and Shakira from the Super Bowl kind of animation. Again, for most of Latinos identify or understand who these individuals are. And the storyline itself, how the story is being told, the characters that we bring in, we try to do them kind of following the kind of telenovelas or soap operas from Mexico and Latin America. And the goal here is going forward, these characters us as the consumers of this information are going to follow these characters through a series of different lessons and different information that's coming through. And as we go forward as well, the project and the data that we're getting from the Central Valley is going to inform what needs to be included in these animations. And so yes, I think I'm almost out of time, but I wanted to just bring that up and show how we are trying to connect research, the empirical evidence, and then use that to create something that's kind of culturally tailored for this Latinx community, and also for different subgroups of Latinx community. One goal that we have is to create something similar for Mixteco and indigenous immigrants, Zapotecos, Mayan, different linguistic groups that are coming from Latin America. So I'll stop there and I'll yield the rest of my time as well. Thank you.
Thank you so much, Dr. Lopez. And I want to tell you that you're getting all kinds of kudos here for that video. And I want to echo that. It's really done quite well. And we're starting to have some questions. I wanted to ask, as we watch that video and as you're speaking about targeted efforts towards the Latino community, I want to ask both you and Dr. Baker, what other efforts have you seen that you feel are successful during this pandemic? And if not, why do you think there haven't been particularly targeted efforts towards education and prevention towards both of the communities that you're speaking about?
So one of the things, speaking from some of the interviews that we're analyzing now from the open-ended interviews, is we ask them, where's your information coming from? Where do you go for information? How much do you trust that information? There's a lot of confusion, a lot of distrust from official government sources. For example, this is one pattern that keeps coming up, CDC information and county information. People don't seem to trust it as much as they do Univision, the news, the national news that's coming through. And it's understandable. This is a community that, you know, historically, some of these government institutions have been trying to shed light on and to some extent get out of this country, you know, with the immigration policies. Through history, this community has been trying to avoid the eye of these, you know, government institutions. So there's a lot of distrust, historical distrust there. So there's something going on where this messaging coming from the government, it's not reaching this community. And they seem to be going to other sources, Univision, and a lot of these national news sources. And there's a whole discourse on that, right? On how a lot of these social issues are being portrayed by these media outlets. So that's another issue that we should look into as well. But to answer the question, yeah, I think that it's a mix of mistrust and where are they going for information and who is the information coming from and how reliable that information is.
Thank you, I appreciate that. Dr. Baker?
Yeah, I'll be real quick. Trust is the biggest issue. And we as providers have done a terrible job of having our patients trust us. You know, we treat them as numbers. We hoard them into a waiting room, have them wait a long time to see us, and they never really feel they're at home, right? So I try in my practice to have my patients feel like I am their only person that I'm seeing for the day. I try to build that trust because the African-American community has had several instances in the past 50 years to show why we would not trust any institution, just to name the Tuskegee experiments. But he was correct when he said CDC is not a trusted source. The Arizona State site is not a trusted source, but people they trust, they're pastors, they're true family doctors, they trust them. That's where the information should be coming out. And we should be doing a better job of having forums, of having ways to disseminate information where they are, not to make them come to us.
Thank you. Thank you so much for that. And both of you really bring up the concept of trust and lack of trust. and really a reminder that this lack of trust is not new. It's really based on lots and lots of history and lots of policies that tend to be very targeted towards both of these populations, as well as the third population that we want to examine today. And at that, I'd like to send it over to Dr. Molina.
Okay, can you all hear me?
We can.
Good. Dios Chemiavo, Dagoteshi, John Molina. Good afternoon, everybody. My name is John Molina, and I greeted you in our Yaqui and Apache language, and appreciate all of you taking your time to be with us to talk about these important features that have been shared with us. And more than anything, I've always felt that we do get a lot of information. And this information is very critical in helping us make informed decisions and to be able to sort of create a path on how we address these disparities and these issues in healthcare, especially in our population of color. But more than anything, I always tell my students, it's always also important to understand that education is just not the filling of a vessel, as Socrates once said, but the sparking of a flame. A lot of our folks out there are in academics, are students, are people in practice, and it's always my hope that as you get this wonderful information that it sparks ways of thinking that are innovative, opportunities that can begin to make inroads in helping us to achieve better healthcare for our people. So I'll have our host switch to the next slide. Good. Okay, just by way of introduction, again, we've been talking about how the importance of meaningful access to care is so important in these times of not only when there's no pandemics, but when there is pandemics, because in times like these, we've already discovered that this lack of a well system of healthcare or a safety net is important. Otherwise, so many people get impacted, individuals, and not only individuals, but we've read across the media that families get impacted. These gatherings that have happened, the whole family gets impacted, and it's a devastating experience, and has been so well illustrated before in this talk. The underlying social, environmental, economic, and chronic health conditions of our people have had this impact, and I think more than ever, I think it's a hope. I hope it's a wake-up call to people in the healthcare industry and public health to say, there's something that needs to be done for a country that sort of brags that we're like the most powerful and capitalistic country in the world, but yet we see our people suffering. My presentation is directed towards our indigenous people or Native American people of this country, and some of the issues that I'll be sharing with you that I feel have contributed to them being also impacted most adversely by this pandemic. So we'll move on to the next slide. First of all, just to say that Native American people, also referred to American Indians and Alaska Natives, are the only population in this nation that have a right to healthcare, And this comes as a result of the treaties that were engaged with tribes and the government in exchange to reduce wars, in exchange for land, in exchange for natural resources. The government promised through treaties that we, the government, will take care of you indigenous people by providing what you need in order to continue to survive and have good health. Social services, housing, education, and healthcare. Currently, there's about 3 million Native Americans throughout the nation. And this is based on tribal enrollment data, not so much US Census data. And there's over 570 tribes that exist in the lower 48 in Alaska. Alaska actually has 229 tribes, a good majority of tribes up in Alaska. And over the last decades, more Native Americans are moving from the reservations into the urban areas to attain better jobs, to obtain education, and to raise their family in an environment that has more resources. So now we're finding that over 60% of Native Americans now live in the urban areas like Phoenix, Los Angeles, Detroit, Chicago. So a lot of our families are moving into the urban areas, which in of itself is a whole different demographic population, because now they're sort of assimilated, if you will, to the Western way of living. What I'll be talking to more about in this presentation is how our indigenous people, our Native Americans on the reservation, tend to be more impacted, because it kind of makes sense. In the urban areas like Phoenix, there's a lot of resources, a lot of major hospitals and institutions of learning, not so on the reservations, and we'll talk about that in just a little bit. Now, the Indian Health Service, whose logo you see on the right-hand side, was created in 1955 by the US government as a way to provide a system of care for Native American people. Again, because we, as indigenous people, have a right to healthcare based on treaties. So what's happened is it's evolved into a 3-domain system of healthcare under the Indian Health Service. First, we have the Indian Health Service, which are federally managed hospitals and clinics. The biggest one being here in Phoenix, Phoenix Indian Medical Center, which is located on 16th Street and Indian School. That's a federally managed hospital under the Indian Health Service. The other entity are tribal health organizations. A lot of tribes like San Carlos, Gila River, Salt River, and Tohono O'odham have taken over the management of the healthcare system from the US government, from the IHS, so they manage the healthcare systems as a separate entity. Then we have the urban Indian clinics like Native Health, where I'm at, which are urban Indian clinics that were funded also by the Indian Health Service to provide healthcare for Indian families that move into urban areas like Phoenix. Collectively, these 3 entities are referred to in Native American language as the ITU system. ITU stands for Indian Health Service, Tribal Health Organizations, and urban clinics. So it's an acronym that you may hear when you're talking about Indian healthcare, because collectively it involves all these three different systems. The caveat here, and which begins to establish this fragmented system, is these systems don't always talk to each other. You would think it's a big health system in of itself, like you would think like Banner Health or Tenet, but it's not. They're separate silos of systems that have separate electronic health records that don't talk to each other. So right there you could see there's a big issue on how we can get health data that represents the Native American population. The other issue with Indian Health Service is the Indian Health Service gets funded at only 26 to 43% of the money that's allocated to other government programs like the VA, Medicare, and Medicaid. So that's another challenge with the Indian Health Service. There's not enough funding to sustain, as they do other entities, the people that are served by the Indian Health Service. And what little money does flow into the Indian Health Service is mostly goes to direct medical care and facilities, with little left over for public health sort of initiatives to be able to address those social determinants of health. So right off the starting block, Indian people are at a disadvantage here. Next slide. Okay, this sort of gives you a layout of how the Indian Health Service system works. It's divided into 12 regions from Alaska, Portland, Billings, Aberdeen, and all the other areas. And under each of these areas, we have a regional office, we'll call the area office. We here in Phoenix are in what we call the Phoenix area, which incorporates Nevada, Utah, and Arizona. And the main governing office for that area is here in Phoenix downtown. Headquarters for the whole region for the whole nation is under the Director of Indian Health Service, which is in Rockville, Maryland. So that just kind of gives you a sort of a lay of the land on how the system is set up. Next slide. Okay, here's a little bit of the allocation of expenditures. To 2017 is the closest that I could get, because things are always a couple years behind. But if we begin on the right-hand side, we see the bar there. For the actual IHS expenditure per user of Native Americans is about $3,332 for their health care. Again, all goes to going for medical care. You go to the extreme left where you see Medicare spending per beneficiary, $12,829. Then you move down to the right, you can look at veterans VA spending per patient, $8,758 per capita per patient. Then you go to Medicaid spending, like here in Arizona, we spend about almost $8,000 per patient, per Medicaid patient in Arizona. Indian Health Service per patient, $3,332. This is another huge disparity that tribes have advocated to try to increase and improve to meet other similar services, but it hasn't happened. That one of $7,515, that's a federal disparity index. That is what Native Americans would get per capita if they were federal employees. So again, Indian Health Service is underfunded. There's been even lawsuits against the government to try to increase funding. But the government's response is, yes, we did promise you in treaties to support healthcare and give you money, but we never said how much. So that's always been the response of the government. Again, we're talking about First Nations people, people who existed on this earth that we call Turtle Island before Europeans came over, before colonization took place. So again, it's a right that Native people have. Next slide. Okay, we talked a little bit about health status, and Dr. Baker did a wonderful presentation on how people of color are impacted more so than the general white population. Native Americans are more likely to be obese, have high blood pressure, be current cigarette smokers in the white population, and all these are risk factors for heart disease. 50% more likely to be diagnosed with coronary artery disease, 50% more likely to be current cigarette smokers, and 10% more likely to have high blood pressure. Now again, when we talk about COVID pandemic, we've already seen that these type of chronic diseases do impact adversely anybody that might be infected with COVID. Increases the risk factor of not just infection, but mortality and morbidity. Now, a higher mortality rate with COVID, again, can be secondary to pre-existing conditions, but we'll talk a little bit also about how other things like the lack of testing and quality healthcare can also impact the Native American population. Next slide. Okay, and again, we've talked about before in this presentation, looking at the left of the slide, how there are so many elements that impact our healthcare, your healthcare, my health status, your health status. Primarily, we think about age, sex, and constitutional factors, but that only really answers about maybe 20% of your health status. The other is represented, and the impact of them is your individual lifestyle factors, social community networks, living and working conditions. And these were talked about really well in the previous presentations. So we know that for us to have good health, there's other more factors than just having good genetics. It's about where you live. In fact, if you want to look at the lower types of, if you want to look at populations that have the lowest health status and are suffering the most of chronic diseases, just look at zip codes. When you look at zip codes and where they're at, you'll find that that's where you have the worst health for population. So again, all these things are important. Now, related to just the Native American population is that it's very unique because first of all, as we talk about ways to communicate information on COVID, again, we do a lot of great things. Culturally competent communication, language, and that beautiful cartoon slide that we saw presented. These are great ways to get the information out because you want to connect as closely as you can to the culture and the way people think in that culture. So you got to put yourself in their shoes in some sense to be able to better understand how to communicate. Now, looking at Native American culture, I'll just begin by saying that we have always been a holistic culture, a spiritual culture, a culture based around ceremony, a culture based around prayer, a culture based around kinship. This is what Native American people are all about and always have been and continue to struggle to be in light of colonialization. So there's a culture of closeness and kinship. You know, like my wife, who's a Lakota, Dr. Stephanie Bicro, she's from Pine Ridge Indian Reservation. She has like 30 grandmothers, you know, 10 fathers, and who knows how many other aunts and relatives, because we believe in a kinship system. So it's not uncommon for there to be 3 or 4 households under one residence. It's okay. We take care of our children, grandchildren, great-grandchildren. That's a part of our culture, because that integration of culture is a way that we teach each other, pass on traditions, pass on stories, pass on language. It's important for the kinship system in order for us to survive as a culture. But that in itself is a negative under COVID. We don't want to get close. I mean, all these folks and media are telling us don't get close. Well, think about how a Native American's going to take that. Well, for me, it's all about closeness. It's all about visiting grandma and grandpa and being there. You're telling me not to do this, but it's so integral to my culture, to my life, to my survival. That's one hurdle. The other one, lack of readily accessible water, more commonly in the rural areas, like up in the Dene country with the Navajo people, because typically we're asking people to have on-the-spot hygiene, wash your hand. And you're right, sing happy birthday. But how far do you have to walk to get to the water? You probably have to sing happy birthday 10 times to get to the water to sing happy birthday. It's a long way to go. Not very reasonable. Water has to be hauled in through trailers and trucks. You have to take care of the water. You have to be careful, otherwise you won't get it. Another impact on Indian people. Indigenous language. There's hundreds of indigenous languages throughout Indian country. And especially on the reservation, we have fluent speakers who speak that as their first language. How do you interpret COVID-19? Well, it's easy for us as medical providers to tell our patients, hey, take care of yourself. We don't want you to get COVID-19 infection. How do you tell that to indigenous patients that don't even understand the English language? Having worked with the people in San Carlos Apache with the healthcare corporation, we beginning to translate into how we can best describe COVID-19 virus infection and complications in the language that people can understand. And sometimes it's not using the scientific word, it's using a descriptive word. How do you describe this? You know, and our indigenous people on the reservations have done a wonderful job to be able to translate from here to there. Transportation, again, with even non-native communities, where you live makes a difference. You live in the rural areas, you got more challenges. Up in Navajo, up in White Mountain, up in San Carlos, you got roads that are dirt, they get washed out. You got a big storm that comes in, a haboob, or the big rain, it gets washed out. How do you get to the care you need to get? Or even to get to the healthcare. Transportation continues to be an issue. Up in Alaska, when we're up there for a few years, there's only 2 main road systems. How do you get to healthcare when you need to get there? How do you get healthcare providers out there to do testing and to do contact tracing? The other thing we talked about a little bit that was presented is about data. You know, Dr. Baker presented data with sort of a blank on Native American. And the reason for that goes back to what I shared earlier. We have 3 systems. We have a big system of care with 3 different domains: Indian Health Service, tribal organizations, and urban clinics. Those don't connect or share data. That's a big gap in Indian Health Service that I'm trying to advocate for, that we need to create a electronic healthcare system or health information exchange that we can exchange that data. Otherwise, we don't know. The only data that we have is how many Native Americans are dying, because obviously that's got to get recorded. 16% were dying from COVID. And yet the population of Arizona Native Americans is less than 6%. So again, data for me is critically important, and that's another big push that has to happen. So in order that this ITU system can talk to each other, can share that data so that we know how many of us are being impacted. Cultural beliefs and taboos, big. Again, like I shared earlier, our people are spiritual. We believe in metaphysical energies, connect us to the universe, to things around us. And things that happen for a reason. A lot of people still believe that. In my own tribe, the Yaqui tribe, a healer once told me, listen to what the disease is trying to tell you. Before you go to the doctor, before you get treatment, think about it. What is that disease trying to tell you? And the way our people think is that that disease is trying to tell you something about the way you're living. Think about it. So for us, when COVID hits Indian country and people are dying left and right, what are they thinking? What have we done? What's happened? I'm not living my life right. Sure, it happens by this little bug that we call a virus of little spikes around it, but not all people think that. If you ask them how they got COVID, be prepared for a different answer. And that's what drives the way they think. That's what drives them to go to the hospital or not go to the hospital. We had, one of our board meetings with San Carlos a month or so ago, we're looking for alternative care sites to put people to self-quarantine or isolate, because again, in San Carlos Reservation, east of Globe, it's difficult to quarantine 2-3 families who live in the same house. So we're looking at the school, at the gym. Well, let's use the gym as alternative care site. But you know what the high school student said? Don't bring him here, because that's bad energy. We don't want the bad energy of COVID to stay in the gym of the high school. That's the way we think. Their energies. And that can be a whole different discussion on how we as Indigenous people look at the world and our domains as being a systems of energy.
I'm sorry, this is Swapna Reddy. I'm so sorry to interrupt, and I've been completely enraptured by your discussion, but I'm just looking at the time, and we have lots of questions, so I'm forced to give you sort of a 2-minute warning, if that's okay.
Perfect. I'm right down the final pathway here. So social media, again, our people on the reservations use social media, and unfortunately, that could be a plus or a negative. You share information, good information, but you also share bad information. That hits people to not understand what's going on. The other thing we've noticed that people talk about other people, they know each other, loss of confidentiality. Tribal leadership on the reservation is important. They need to be unified to take out the message. And again, during this Census Bureau timeframe, very difficult to really know the population numbers of Indian people. Next slide. Again, just a quick look at this. Navajo has been on the news, really impacted, infection rate 3.4%, big country, highest infection rates per capita as of June 14, 6,600 deaths. Physician vacancy rate at 26 to 40%. Again, Indian funding, and you can see a picture there of a hogan that's out in the desert, unemployment rate of 48.5%. And then the last slide, I believe. Okay, a call to action. My call to action is that we have to unfreeze federal funding, especially for housing. And this was brought up before the National Congress of American Indians. We need more funding for adequate housing and water. Increased funding for IHS. You've already seen how lack of funding has impacted healthcare facilities and healthcare providers. Increasing broadband activities. Rural areas, we need a broadband activity, make use of telehealth. And finally, safe and secure voting. We need to have our voices. And if we can't register to vote, or difficult to register, or difficult to vote, then we become an underrepresented Indigenous country. Next slide. And that's it. So social distancing, again, we're trying to impact our people. It's beautiful. Think of your children, think of your grandchildren, think about the next 7 generations, and what you're doing now will impact those future generations. So with that said, thank you.
Thank you, Dr. Molina, beautifully stated. And as I mentioned, I think we are also enraptured and wrapped in learning, actively learning from your talk that we didn't even notice the time, but we have lots of questions. And so we're probably not gonna have enough time for most of these questions, but just wanted to ask a few. One relating to masks, which is highly relevant, especially in relation to the recent policy in the state as of yesterday that local municipalities and mayors are able to mandate masks. Wanted to ask all three of you about access to masks in the populations that you're discussing, and also openness and attitudes towards wearing masks, but also any potential mandates towards mask wearing.
So I've been talking about this probably since about February. I thought everyone should be wearing masks. I've spent time over in Asia, and everyone walks with a mask. But let me just show real quickly what the three different types are. This is a face covering. It's cloth. People make it out of scarves and everything else. That is what's being advised by the CDC as your protection while out in public when social distancing is inappropriate or you're able to do. This is a surgical mask. You see a lot of people with them. And this is an N95 mask. So the N95 mask, surgical masks, are medical masks, and they're harder to come by. They've been in shortage, which is why they changed their belief that you should use cloth masks. If you can get them, you can find them on Amazon. Surgical mask, this is what my family wears. If you cannot get them, use cloth masks. You can make it out of t-shirts or anything else. Anything to help your respiratory droplets from getting out, and anything that will slow anything to get into you, it would be helpful.
Thank you. Thank you so much. We appreciate that answer. You know, there's another question, as we spoke so much today about trust, lack of trust, and really these kind of historical determinants mixed with current social determinants and also the healthcare delivery system. There's a great question here about diversity in healthcare. And Dr. Baker and Dr. Molina, specifically, the question is to you. The question is, as a Black male physician and American Indian physician, what advice do you have for underrepresented minority students who are looking to gain admission to medical school, considering the lack of URM representation in the current medical system? And how important do you think that is for a pandemic such as this and moving forward?
Dr. Baker, you want to go first?
Sure, I'll be quick. It's extremely important. My son is part of NSBE, which is the National Black Engineering Society. He's a young kid, he's 15. Get your kids into these science, STEM type programs. Invite me to come and talk to them, and invite Dr. Molina. They have to see it to believe it.
Right.
You know, so that's what it's all about. That's why my title is important. When I'm around little Black kids, little brown kids, yeah, I'm saying, hey, I'm Dr. Baker. And they say, wow, I can actually be that. So.
Absolutely. I think that's a big thing. You know, and then the other thing is that I am a member of the Association of American Indian Physicians, a nationwide organization where we have pipelines, where we are where we mentor high school students and college students into beginning to expose them to the medical field. And our indigenous doctors are also mentors like you, Dr. Baker, who come to these conferences, and we bring these young kids to these conferences at no cost, because it's funded by other corporations, to begin to bring them into the world of medicine. And that's important because, like you said, our people increase that trust when they see someone just like them. Sure. It makes a big difference.
Thank you so much. I'm really sad right now because apparently it's already 2 p.m. And this has been a fantastic conversation. We have so many questions. I'm sorry that we weren't able to get to all of them, but I want to wholeheartedly thank all three of you for joining us today, not just to tell us a little bit more about these very important issues, but to really dig a little bit deeper and have honest conversation and open a dialogue for honest conversation about the social, economic, and historic injustices that are at play right now, especially since that's such an important dialogue that we're having right now. And also, I want to thank our audience. We've had around 100 people today join us. So thank you so much for your interest in this topic. It's a tough topic, but a necessary topic, and one that we all have to be a part of in order to be part of the solution. So with that being said, I want to thank all three of our speakers and our entire Health Talks team and all of our audience today. Thank you so much for joining us, and we wish you good health and peace. Thank you.
Thank you.